Welcome all of you to this live program in Orthopedic Principles. Today, our guest of honor is Dr. Nicola Archetti Netto from Sao Paulo, Brazil. Dr. Netto is a consultant in shoulder and elbow surgery. He's also affiliated professor of the Orthopedic and Trauma Surgery Department at the Universidade Federal de Sao Paulo in the discipline of upper limb surgery in Brazil. He also holds an MSc and PhD in postdoctorate in medical science. So today is my great honor to introduce you to Dr. Nicola Archetti Netto from Sao Paulo, Brazil. Over to you, Dr. Nicola.
Thank you, Dr. Gopalan. It's really a pleasure for me. It's an honor to be here with you and our friends. Today, I'm going to talk about the subject that really interests me a lot. It's how to plan a reverse shoulder arthroplasty for fractures using the anatomical parameters. I have this conflict of interest. So, as we know, the proximal humeral fractures are something very frequent in your daily practice. And it's a common disease. And we all know that the conservative treatment is still the best. The majority of the situations like this are treated without surgery, and the patients go very, very, very well. And the surgical treatment, the ORIF, is today the good standard for this kind of situation and give, as all you know, the better results. This is the way that I've been doing this osteosynthesis of the proximal humeral fracture when there is a great comminution and a compaction of the cancellous bone. I've been using a structural graft. This graft is made is not a bone, in fact, it's something derived from the carbonate sodium that you can use as a structural graft to support the head. It's a good solution for this kind of situation. Not for all patterns of fractures, but when there is a comminution and a compaction, that is a very, very good way to avoid the cutting and the penetration of the screws. So speaking about the shoulder arthroplasty is another situation that you can use to treat these patients. And today you have the ME arthroplasty. There's something new by years, was introduced by Dr. Neer, and the reverse shoulder arthroplasty. This kind of indication, at least circa 5% of these patients are need to do this kind of intervention. So what are the factors involved in the decision-making process? We have to see all the patient characteristics, the activity of living, the independence of living, the morbidities, all the disease that the patient will have, the fracture characteristics. The fracture characteristics is important for me, for example, the quality of the bone, the presence or not of the medial ridge, and the possibility to make a reconstruction with an ORIF, if you want or if you need. And there is, of course, the surgeon preference and experience on treating these patients. And you have this quotation, that's something very present. I always say to my fellows, we don't treat the X-ray, but the patients. But what are the indications nowadays for shoulder arthroplasty in this scenario? We have to evaluate the bone quality. The comminution is one of these indications, especially the great tuberosity, and when the patient has osteopenia for avoid complications with osteosynthesis. When you have an articular segment, or for example, pre-existing arthritis, an ischemia, here in Brazil, we have a situation that we have to treat patients that had a trauma occurred by a month. And for example, when the patient has fracture luxation, this is a situation of ischemia of the mainly of the epiphyseal part of the head of the humerus is something that can maybe be better with an arthroplasty, the head impaction also, and the head split. Related to the patient factors, that is the comorbidities, as we know, the advanced age and other associated injuries. Today, we still have debate relating the use of not the hemiarthroplasty versus the reverse shoulder arthroplasty. All the studies are showing that the results of the reverse shoulder arthroplasty in the trauma scenario is much predictable than the use of the hemiarthroplasty. All you know that when using an hemiarthroplasty, it's a great risk in terms of function because we don't know if the patient will have a good range of motion or not. When it have a good range of motion, I think it's an exception. And for the reverse, in some situations, this kind of outcome is better. So we have to think about the reverse in the scenario of a poor cuff when we have a GT comminution, because when I have a good GT, you can use an any in a young patient, for example. The advanced age, the osteoarthritis, we know about the predictable results, but what you have to do in a younger patient. I think this is the challenge because in a younger patient, if you do a reverse, you are burning at the bridge. You can go back, and so maybe thinking about maybe a kind of a scalonate treatment, doing a reverse with doing an any with steam for fractures, convertible, and later, if it's need, you can do a reverse. And now we know we have this economic impact of use of this implant in our country here in Brazil. We don't have access for all the patients, mainly in the public health system. But what are, in my opinion, the keys for good results when we are doing a reverse for a fracture? We have to avoid the instability, that is the major complication. For doing this, we have to put the components in adequate elongation in place and version. We have to have an adequate reduction in tension and fixation of the great tuberosity. But all you know that something questionable about this topic. But when you have a great tuberosity in a good quality, it gives a better outcome for this patient, mainly in the reverse shoulder arthroplasty. And you have to think about the postoperative mobilization. That is something important to heal the tuberosities around the prosthesis. So what is the main technical challenges during the surgery? We don't have parameters. For example, this kind of fracture, we don't have any parameter to make this kind of reconstruction. We have to think about the healing of the great tuberosity to give us stability and better results, giving adequate tension around the prosthesis when the great tuberosities. And we have to use, if it's possible, the stem designed especially for fractures, but because they are different from the stems used from other kind of situations. Thinking about anatomical reference for making a reverse or for making a shoulder arthroplasty, you have to see this work made by a group from Brazil with Dr. J.P. Warner in the United States. They used 40 cadavers, shoulder of cadavers, and make a measure of the distance between the top of the pec major and the top of the pec major to the top of the prosthesis, and they defined it as 5 centimeters. So this is a landmark, as important landmark when they are going to do an hemiarthroplasty. but we don't know how it works when we are doing a reverse because the design of the prostheses are totally different. More recently, there are some papers. This is one from Dr. Joaquin Sanchez-Sotelo from Mayo Clinic, making all these measures again using onlay prosthesis for shoulder fracture. And he made in 20 shoulders of cadavers the measures that can guide using this specific kind of prostheses that are made by Stryker. They make this landmark of 4 centimeters from the stem. This 4 centimeters is related to the upper side of the pec majors, and the pec major to the top of the stem. But when you are using the insert of the stem, you can calculate at 4.8 centimeter, as you can see. You can see this to make this exact measure of the patient. But we have to think about the size of the patient and the variation of all these measures relate to the implant and to the size of the patient, but it's something very good to make a good orientation during the surgery. That is this last paper that is very interesting. This author showed that these measures that they did don't diverge when the patients are from different sizes. And there is a very interesting landmark also. They measure this CDD distance, this cuff to deltoid distance. So they measure the insertion of the deltoid to the top of the head and measure the top of the pec major to the medial part of the head. And they read these results: 87 millimeters, plus minus 10 millimeter for this called CDD measure. It's from the deltoid to the cuff, and 16 millimeters minus 7 millimeters for this PND measure. That's something you have to have in mind and use in different situations. I'm going to show you this case. This case is a lady with 75 years old, right-handed. She had a split head fracture. So we opt for a reconstruction with reverse. And I'm going to show how I can use these measures during the surgery. I usually use this system. This is an inlay system with a 145 degrees. It's a modular system. And we do what? We do a deltopectoral approach, as a regular deltopectoral approach. And you can find the long head of the biceps. This long head of the biceps is our landmark to separate the tuberosities. In the right side, that is the head, the split head. And it's easy to take it off and separate the tuberosities. As you can see here, we expose the glenoid. It's very important to take out all the parts attached in the glenoid to see and to have the correct version for implanting the glenosphere. This is the guide wire that we use to guide the position of the glenosphere. This guide wire is important is to put with an inferior tilt of 10 degrees to have a good result without an impact and a notching. And another thing that's important is to drill carefully, because in this situation, we are not treating an arthritic shoulder. This bone is soft. So you have to be very careful doing this and do the central hole for the system. In the system, we use this base plate with 2 compression screws they are not locking. And you put the glenosphere, we use the 36 for ladies and 40 for men. It's only to relate to the size of the patient. And here, how I can make the measures. I use the upper part of the pec major, and I used to measure approximately 5 centimeters, that I think it's a good distance. And this distance I can compare with the distance that I use to do, for example, a rotator cuff arthroplasty. As you can see here, I'm using the same measure. So to the top of the head, to the upper part of pec major, that is 5 centimeters, so I can reproduce for this system. So we have to be aware that if you are using different kind of prostheses or different models, we can see that measure can change, can change or can have a height variability. Here, this is a device as a rule to make this measure. This kind of prosthesis is a modular. We use a stem like the Wagner stem from the hip. This is a triple conicity stem. You can do this. It's a press fit stem that I think is good for this fracture scenario because you don't use cement. I think the cement, mainly in the upper part of the fracture related to the tuberosity, is something that can make a change on the, or can make the healing of the tuberosities much more difficult. So the idea is to put this this press fit implant, and as you can see here, we have some things that you can put the sutures through these fins to adapt perfectly the GT tuberosity. And here we are using the trial and correcting the version from 20 degrees that is recommended for this kind of prosthesis. And you can see all the suture here embracing the tubercles, the tuberosities. And the objective of this position in the height of the prosthesis is to adapt or to make a perfect reduction of the great tuberosity. As you can see here, I'm trying to reduce in a perfect way, let's say in this way, giving the perfect height to the prosthesis, doing a reconstruction, as I said before. We can see here that you can make all the circlage with the tuberosities and with the prosthesis. There is an important step in this procedure that I'm going to show you now how to do it. I always do in this way. I put the 2 double sutures, in fact, 3 double sutures around the tuberosities. One of these I put medial to the neck of the prosthesis. This is a colored around the word suture. This was described by Dr. Bolo and Dr. Gilles Walsh, and make a very good compression with the tuberosities around this prosthesis. You have to remember that these stems are made for this situation, so you can make a very good reduction with all the tuberosities. And we also do two sutures in the tuberosities, the lesser and the great tuberosities, to the diaphysis to make it very, very good fixed around the prosthesis to have a great heal. I use this kind of knot that was described also for Dr. Bolo. This is a square knot with a double loop, and you can put the free tail inside the loop, and then we can slide this loop. It's a very good knot. We slide it, and it gives a very good fixation. And then we make some half stitches to make it blocked, and that is a fantastic way of doing this. This is the post-operative result of that case. You can see that we make a reconstruction like a cuff arthroplasty, giving the correct positioning and healing of the tuberosities. As you can see here, this is an X-ray with 6 months post-operative, and that had a heal with this tuberosity without at least a little bit of reabsorption. That is normal, but giving a good function for these patients. And here is a measure showing that when you do this in this correct way, making all the positioning, we don't have changing in the length of the humerus. As you can see here, the length of the humerus, considering the top of the prosthesis, are similar to the other sides of the patients. So this is our objective of doing this kind of reconstruction and concluding the indirect anatomic parameters can help the positioning of the prosthesis in the components. We have to have attention to implant design variation and attention to reduction and fixation of the great tuberosity. It's that I can.
Thank you, Nicola. Yeah, you can stop sharing.
Okay.
Thank you, Dr. Nicola, for this detailed presentation. And congratulations for all the work that you do in Sao Paulo.
Thank you, Tesh.
Dr. Nicola, just a few questions. I know that you're busy with the clinic. Now, what about the complication rates when you do reverse in a fracture versus a cuff tear arthropathy?
You mean if there is a difference when I'm doing a reverse for a fracture in a rotator cuff arthropathy? The major complication is the instability. But the instabilities can avoid correcting that thing that I said, making the correct position of the tuberosities with a good tension, and we make a good circulage and trying to avoid all types of impact in this situation. But I think that the worst scenario and the scenario that you can have more complications are in the scenario of the when this fracture are consolidated, or, for example, there is a sequela. This is another situation that's in terms of range of motion and satisfaction is not good for the patient. So I always think the first shot is the best shot. When I'm trying to do this, I'm trying to solve the problem, not trying to postergate the situation that I think can be worse and can have more complications doing this.
Thank you, Dr. Nicola. And Dr. Nicola, what about patient selection? Now, you do reverse shoulder arthroplasty only for grossly displaced fractures, say, for example, fracture dislocations. Or even, do you do ORIF at all in your clinical practice?
Yes, most of the cases I do ORIF. For me, the prostheses are an exception, let's say in this way. I think in our countries are different for example, United States, in Europe, the indication are different. The condition, the way that the health works are different. Here in Brazil, we don't have this kind of prosthesis in the public health system. We don't have it when the patient has a insurance, something like this. In Brazil, 30% of the people only has this kind of insurance. So this is something that impacts in your, let's say, in the quality of our treatment. So I always think in making it in a good way, to make in a reasonable way, and doing only when it's needed. But I prefer when I can do osteosynthesis.
Thank you, Dr. Nicola. And Dr. Nicola, just one last question before we wind up the session. Now, these are all elderly fractures, right? They are like 70 plus or 80 plus. And once you've done the reverse, do you put on some kind of anti-osteoporosis treatment? Any particular drug that you use, say teriparatide, denosumab, or any other particular drugs?
Yes, we've been using in Brazil this, but how I can do it normally? That in Brazil there is a field of orthopedics that is specialized in osteometabolic disease. And when I treat a patient like this, I only refer to this colleague to make all the treatment, the good treatment that I really don't know how to do it pretty well. So this is the reason that I refer to the other professional, but I think something very reasonable and good for the patient.
Thank you, Dr. Nicola. Dr. Nicola, thank you. That's all the questions that we have for this session. Thank you for this great presentation. And now you can go ahead with your clinic.
Thank you, Tesh. It was really a pleasure.